Every single time you go to the doctor, any diagnosis, and I mean anything, from the flu to a super complex blood disorder, gets a special code. And it's not just about billing, not at all. It's really the language of modern healthcare data. So today, we're going to crack that code, specifically for Chapter 16 of the ICD-10-CM, which is all about diseases of the blood and the immune system. Let's dive in. So just so we're all on the same page, everything we're about to cover, it's coming straight from the source text for Chapter 16. This is the official guide that organizes this huge range of conditions, from the anemias most of us have heard of, all the way to really complex coagulation defects and immune disorders. So let's take a look at what's on the docket. All right, here's our game plan. We're going to start with the big picture, get some key vocabulary down. Then we'll do a real deep dive into anemia. After that, we'll tackle the specifics of hereditary conditions like sickle cell, then get into clotting and bleeding disorders, and we'll wrap things up with white blood cells and the immune system. Okay, first things first. Before we can get into the nitty-gritty, we have to speak the same language. This whole section is about building that foundation, defining the key conditions you're going to see over and over again in this chapter. Let's kick things off with the most common one you'll run into, anemia. As the source defines it, this is all about a deficiency in your red blood cells, or in the hemoglobin that they carry. And honestly, this is probably the condition that coders see most often from this chapter. The causes can be all over the map, from chronic diseases to sudden blood loss. So what happens if it's not just one type of blood cell that's running low? Well, that's where pancytopenia comes in. You can think of it as a kind of triple threat. You've got low red cells, low white cells, and low platelets. This usually points to a much bigger, more systemic problem, often starting right in the bone marrow. And that's a perfect lead-in to aplastic anemia. What's so important to see here is the focus on the cause. See, other anemias might be about losing blood or the body destroying cells, but aplastic anemia, that's a manufacturing problem. The bone marrow itself, the body's blood cell factory, is failing to do its job. Okay, now that we've got the basics down, let's really dig into anemia a bit more, because it's not nearly as simple as just slapping on one code. The reason for the anemia is absolutely everything, and the coding guidelines are super specific about how you need to document it. So, let's play out a really common scenario. Imagine you're a coder, and you see a lab report. The hemoglobin is low, the hematocrit is low. It's screaming anemia, right? So can you just go ahead and assign the code? What do you think? And the answer, coming straight from the official guidelines, is a hard no. A lab test can support a diagnosis, for sure, but it can't make one. The physician has to be the one to document the clinical significance of those lab results. So the bottom line is really clear. If there's no physician diagnosis in the record, you cannot assign an anemia code. Period. This slide just perfectly illustrates how important sequencing is. The rules are crystal clear. The underlying condition that's causing the anemia gets coded first. And this isn't just some random rule. It's about telling a logical story of cause and effect. If a patient is anemic because of chronic kidney disease, you code the kidney disease first. It's that simple. This makes sure that when we look at the data later, we're seeing the primary problem. Now, the one big exception here is anemia from chemotherapy, which has its own special sequence to make sure we highlight the adverse effect of the treatment itself. All right, let's get even more granular. Let's say a patient has surgery and develops anemia right after. How do we handle that? It's a type of acute blood loss, sure, but does it get the same code as, say, blood loss from a major car accident? The answer is no. It actually gets its own unique code D62 for acute post-hemorrhagic anemia. And this is a big but, there's a catch. The doctor has to explicitly document that this anemia is a complication, not just something that was expected to happen. Think about it. For a lot of major surgeries, a certain amount of blood loss is totally normal. It only gets the special code if it's a complication that needed specific medical attention. Okay, let's see how this all connects. Shifting gears from acquired conditions, like the postoperative anemia we just talked about, to hereditary ones. And here, we're going to focus on one of the most critical distinctions in the whole chapter, the difference between sickle cell disease and sickle cell trait. This is so important to get right. Sickle cell disease means a person inherited the gene from both of their parents, and they suffer from the symptoms of the illness. Sickle cell trait, on the other hand, means they only got the gene from one parent. They're a carrier, but they don't actually have the disease. The coding guideline here is explicit. If the medical record says trait, you code the trait. You never, ever assume it's the full-blown disease.
Okay, so we've talked about the shape of blood cells. Now let's talk about how they stick together, or don't. This section deals with coagulation defects, which is the whole spectrum of conditions where blood either doesn't clot enough, which leads to bleeding, or it clots way too much, which leads to dangerous blockages.
So at its very core, a coagulation defect is all about a prolonged clotting time. And as the source points out, this can be something you're born with, like hemophilia, or it can be something you acquire later on because of medications or other illnesses.
So how in the world do you code for a patient who's on a blood thinner like warfarin? Well, it's actually a multi-step process. First, you have to code the reason they're on the drug in the first place, maybe something like atrial fibrillation. Second, you add a specific code that shows they are on long-term anticoagulant therapy. And third, if they have a complication like a bleed, you have to add codes for both the hemorrhage and for the adverse effect of the drug. Every single one of those pieces is vital to paint the complete clinical picture.
All right, for our final section, we're making a big shift. We're moving away from red cells and platelets and focusing on the body's defense system, the white blood cells, also known as leukocytes, and the bigger immune system they're a part of. Take a look at this diagram from the source. It shows our key players beautifully. You can see the familiar red blood cells, but check out the variety in the white blood cells. You've got neutrophils, eosinophils, basophils. These are all different kinds of leukocytes, and they each play a huge role in fighting off infection. And of course, disorders can affect any one of them. When it comes to coding these disorders, the very first question is pretty simple. Is the count too high or is it too low? For example, a low neutrophil count is called neutropenia. A high white blood cell count, generally speaking, is leukocytosis. The direction that number is moving is your first step to finding the right code.
And here's a fantastic example of how the coding system has to keep up with modern medicine. Cytokine release syndrome, or CRS, is a really serious inflammatory response that we sometimes see with cutting-edge cancer treatments like CAR T-cell therapy. It's a powerful reminder that as medicine evolves, the language we use to describe it has to evolve right along with it.
So as we start to wrap this up, what's the big takeaway from all this? I mean, all these rules, all these codes, these sequencing guidelines, they can seem really technical, but they all serve one single purpose. At the end of the day, precise coding isn't just for billing or for stats, it's the standardized way we tell a patient's complete clinical story, making sure that everyone involved in their care understands exactly what's going on. And that really leaves us with one final thought to chew on. We've seen how codes adapt to new therapies that cause things like CRS. So, as our understanding of genetics, blood, and the immune system just continues to explode, how will this whole classification system need to evolve to accurately capture the next generation of diagnoses and treatments? That right there is the ongoing challenge.